Today's video is going to be looking at ribs, very superficial look, and we'll be looking at basically the upper two ribs, which are almost purely pump handle, the middle ribs, which transit from pump handle to bucket handle, but are mostly bucket handle, and then the lower from 3 really till 10, we're going to say they're all bucket handle, although they do transit. And then the last two, the floating ribs, which are a caliper motion. We'll be looking at the biomechanics and the test and treatment for these ribs when they're subluxed. It's worth noting that the ribs have really a number of functions. For protection, a solid thorax would be better, obviously. If the vital organs were completely surrounded in bone, that would be the best protection, but then it couldn't move, and so respiration would be severely limited. So you have a compromise. You have part bone and part not bone, but this would give you a flaccid chest because the interspaces between the bones will collapse inwards during inspiration and expiration, which you see with a paralyzed chest. So in order to overcome that, the spaces are loaded with muscle, which not only have the effect of working during forced inspiration and expiration to actually increase the thoracic volume by lifting and lowering the ribs, but they also help the rigidity of the chest. By contracting, they prevent these intercostal spaces from collapsing inwards. The first two ribs function is really about holding the lungs up. So mostly breathing, the biggest muscle of respiration is obviously the diaphragm, and that descends. And as it descends, it pulls the base of the lungs down with it, so it's attached to the pleura. Now, something has to stop the top of the lungs from dropping down with it as well, and has to counter the pull of the diaphragm. And this is done by the scalenes pulling up on the first two ribs. The first two ribs are massive. They don't have an awful lot of movement, and their job is about stability. So these two hold the lungs up through their attachment with the pleura again. So the lung stays high and is pulled down. So the pressure drops in the lungs, air is forced into the lungs, and there's your inspiration. So these are probably the main functions of the respiratory muscles and the thorax, as far as I'm concerned for this video. One of the main determinants of how a rib moves during respiration is the angle at which the head attacks the vertebral body. Now, this picture shows the transverse processes going from 1 through 12. And what you can see is 1 and 2, they come out almost horizontally, but there is a slight change in the orientation between 1 and 2. But when you look at 4, that angle increases considerably, and then still more with 7, and then 9 it starts to reverse itself, and 12 it's almost vertical. Now, this is going to change the way the rib moves. So if you think of the head of the rib at the costovertebral junction as being relatively fixed, so basically what it can do is spin, and then the rest of the movement occurring along the transverse process. And if we look at the transverse mainly, then if the transverse process is vertical and the rib is spinning, then it's going to lift the front of the rib up and down during inspiration and expiration. If the rib is more vertically inclined, anterior and posterior, then it will lift the side of the rib out this way. This one back here will allow spinning on both surfaces, and it will allow the rib to move further in and out. So it's more capable of moving, gliding forwards and backwards, because the head of the rib is sliding along its facet as well. So this will allow the rib to open out this way. So it's been opened and closed in front of it. Now, this all bears a major influence on the preference the rib has to move. Now, that's going to be altered by respiratory patterns as well. So somebody with poor breathing patterns, it may not apply to most of the ribs. But on average, this is how it works. And you'll see that the action of the rib, the movement of the rib, varying from the upper to the lower levels. And we'll look at that right now. Okay, so upper, middle, lower ribs, roughly. So the upper ribs are coming out horizontally. This almost precludes any other movement than the pump handle movement. And pump handle movement, as the pump shows, is an up and down movement. So these, during inspiration, the front of the rib goes up. During expiration, the front of the rib goes down. This is pump handle movement. It's a very simple movement. From 3 through 10, it transits from that flexion and extension movement, the pump handle movement, into a bucket handle movement, and then it starts to ease its way back to a different movement again. There's transition zones at the top and the bottom, but on average this produces abduction of the rib, which is a bucket handle movement, as if you're taking the bucket handle out from the side of the paddle. And if you imagine it's got two paddles on it, or if you like a shopping basket in a supermarket, both handles come up and down that way. So this is abduction of the ribs. And the lower two ribs, which are unattached to the front, and the way the facet forms its orientation there, this will give you a movement as if a caliper is opening and closing. So this is medial and lateral rotation of the rib. It would be lateral rotation during inspiration and medial rotation during expiration. In fact, though, these two lower ribs mainly function as attachments for the diaphragm to give it a stable base to work from. So it has two functions. One is to increase the volume of the thoracic cavity, but also to give the diaphragm an anchor to pull from. So we'll be talking about these types of movement as we go through this, and then we'll also add in what the glides are. But these are basically the average osteokinematics for the ribs as you go from top to bottom. As I've already said, with ribs 1 and 2, they're primarily pump handle movement rather, which is flexion and extension. If you think about the shoulder, for example, that forward backward movement is flexion and extension. So it moves up in the front and down at the back during inspiration, and reverses this movement on expiration. That's its primary osteokinematic. Arthrokinematically, the rib moves anteriorly, ventrally, and down along the transverse process. So the rib is actually tipping down and inwards, and you can feel this if you palpate the angle of the ribs there. And it moves down and in, and then when you expire, it comes out, back and out. So it's dorsolateral gliding there. So ventromedial glide and inspiration, dorsolateral glide and expiration. And as I think I said before, the main function of these ribs is not its movement, although it does obviously move during forced respiration, but its stability as a counter towards the diaphragm's pull. And the ribs are massive for that reason, to be able to oppose this. The test for these ribs, the definitive test, is the arthrokinematic glide, and now you glide the rib ventrally and medially, and you scoop it out dorsolaterally while stabilizing the trunk, or if you're really pedantic about it, you can try and stabilize the vertebra as well, and you have to do that through the neck. It's usually not necessary though, because this end field is very much on the surface. As there's such little movement going on here, you can pick up the normal end field rapidly, and abnormal ones are just sitting there waiting for you to feel it. Treatment of this, you can either directly thrust on the rib, and my preferred technique is a snooker technique, where you basically side bend the head, as you'll see in the video, onto your hand, and then you thrust with both hands in that ventromedial direction. If you want to do it the other way, which is actually a technique that I prefer to this one when you can do it, you basically stabilize the rib. So it's a supine technique, patients down on the back with their arms crossed. You stabilize the rib, and you thrust the vertebra dorsolaterally, relatively bringing the rib ventromedially. That one, when you can do it, I think is a better technique. It's tighter, it's faster, and I think it's better all round. The problem with it is, if you do this, it's not really very easy if you've got a big relative size difference between the two of you. Also, you've got to make sure that the patient's elbow points are not in your ribs, because you'll basically damage the costed costochondral, costosternal joints if you do that, and they take a long time to get better. But all in all, I think I prefer the second technique, not least of which because I actually developed it. So there. Here's the diagram for the osteokinematics and arthrokinematics. Red is inspiration, blue is expiration, and what you can see is the front of the rib lifts up. The sternum comes with it, of course, the whole front of the chest is lifting upwards during inspiration. And for the arthrokinematics, you can see the ventromedial glide is for inspiration and the dorsolateral glide is for expiration. Okay, this is the snooker technique. Soft bit again on the angle of the rib and on the outside angle of the rib. There, that goes down there. So side bend the head away. That's the first thing you do. Put the hand in on the rib, find the rib, extend the wrist there so the pisiform comes into their neck. Then bring the occiput onto the pisiform and thrust. All right? Both hands. So it's this position here, and roll over. That's the grip, up high on the neck. As you're rolling, you pull down onto the rib, that way, and you try and lift them onto the hand there, get the points of the elbows out of the way, and your thrust is that way. Second. Okay, so ribs 3 to 10. By far, the average movement is bucket handle, although I'd say there's transition areas at the upper 2 levels and the upper lower levels as well. But it's probably bucket handle, which is abduction. So as you breathe in, the rib moves outwards and upwards. As you breathe out, it moves downwards and inwards, just as a bucket handle would. Now, at the costotransverse joint, the movement is as you breathe in, the rib will glide dorsolaterally and it will glide ventromedially during expiration. So it's the opposite of pump handle type movement. The test for this are those glides. So basically you stabilize the vertebra and you glide the rib dorsolaterally. You scoop it out again dorsolaterally for inspiration and you glide it ventrally and medially for expiration. Treatment here is a distraction minute. This is the one that's the first technique we would show, and it basically is a distraction technique for the costotransverse joint. We're modeling the subluxation at that joint, and it seems to work okay. You push the vertebra posteriorly while the rib is stabilized. So the patient is supine, you stabilize the rib as you'll see in the video, and you thrust through the folded arms and trunk to move the vertebra backwards. So that will distract that joint. So this is going to be good for both inspiration and expiration subluxations. And here's the diagram depicting those osteokinematics and the arthrokinematics. So, well, I can't show it coming out and up, I can show it going out and in. But imagine that it's actually lifting upwards and outwards during inspiration and it's falling downwards and inwards during expiration. So the red arrow is inspiration, the blue arrow is expiration, and it's the same for the glides along the costotransverse joint. A bit more. So we're going to do left rib distraction, so it doesn't matter whether this is ventral, ventromedial or dorsolateral glide. This distraction, hands up, good. Roll him over. This grip, you can either come in this way or you come in that way. So I'm going to come in this way, we'll set this up by the scapula. This is a more difficult technique. Down there, roll him, lift him onto the distal phalanx of your thumb, find it, thrust. If you have to, use this, in fact use this anyway, in there and bring the phalanx up so it's higher than the femur. Okay, what else? Okay, of course 11 and 12 are not attached at the front. This allows them a freedom of movement that the other ones can't achieve. It allows them to move away from the sternum, and this is exactly what the front ends of it do. With inspiration, the ribs will move laterally. The front ends will separate, which means that the back ends actually approximate. And this is what gives them their arthrokinematic as they slide along the almost PA orientation of their transverse processes. And of course, the costovertebral joints are also orientated more PA, so it allows them a lot of gliding in that direction. So it allows them to open up, and on expiration it will close down. So the glide for inspiration is the same as bucket handle movements. It's the opposite, sorry, of bucket handle movements. During inspiration, it will glide ventromedially, and with expiration it will glide dorsolaterally. But you won't find the upward vector and downward vector that you'd find with pump handle and bucket handle ribs. These are much more horizontally inclined and have most of that vector missing. Here are the arthrokinematics for the floating ribs. And basically, this is opening like a pair of calipers. It means that as you inspire, the rib laterally rotates, and that will bring the angle of the rib, the neck of the rib rather, down the transverse process and the more vertical costovertebral joint. So it's got plenty of movement for it to allow that, and it allows that rib to move laterally. Of course, the only reason it can do that is because it is unattached at the anterior aspect. The glide, therefore, for inspiration is ventromedial and dorsolateral for expiration. I hope this very brief introduction to rib biomechanics assessment and treatment help you understand the subject a little more than maybe you did before. It is meant to be part of a classroom approach. Hopefully the familiarity from this video will help you understand what's happening in class a little better. I will see you again in a few days, and take care all. Bye-bye.